Yes, please go ahead.
So good evening, everyone, and I thank everyone, especially to the lung cancer for the inviting me for this lung cancer conference this year. So the topic today given to me is telisotuzumab vedotin monotherapy in patients with previously treated CMET positive advanced non-small cell lung cancer. So the background MET activation, pathway activation plays a crucial role in the normal development through mediating mesenchymal epithelial interactions and or also in the liver and skeletal muscles. The MET proto-oncogene is located in the 7q chromosome and it encodes a cell surface receptor tyrosine kinase inhibitor known as c-MET activated by its ligand hepatocyte growth factor. So MET pathway activation in malignancies can occur through activating mutations or MET amplifications. So, MET amplifications occur in 2 to 3% of squamous cell carcinoma of lung, whereas MET mutations are noted in 2% of squamous cell carcinoma as per the Cancer Genome Atlas. So several therapeutic strategies have been employed to target the MET in non-small cell lung cancer using monoclonal antibodies directed against the MET or the TKIs, but none have shown efficacy in unselected patient populations. So telisotuzumab vedotin, formerly known as ABBV 399, is a first-in-class antibody drug conjugate comprised of ABT700, an anti-c-MET monoclonal antibody linked to MMAE or the monomethyl auristatin E, a potent microtubule inhibitor. So ABT700 inhibits the AGF dependent or the MET dependent and the independent c-MET activations. It inhibits the c-MET receptor dimerization and has shown anti-tumor activity in MET amplified non-small cell lung cancer and gastric cancer also. So telisotuzumab vedotin is a cytotoxic to cancer cells with c-MET overexpression and demonstrated anti-tumor activity in human tumor xenografts. So this trial was excuse me. So this was a phase 2 trial and eligible patients were identified through the screening platform were required to have c-MET ISC positive squamous cell carcinoma as defined by an H score of 150. Patients were enrolled in two cohorts 1 and cohort 2. Cohort 1 was the immune checkpoint inhibitor naive and the cohort 2 was ICI refractory, which included patients with a history of prior immunotherapy at any point in the course of their treatment. So telisotuzumab was administered intravenously at a dose of 2.7 milligram per kg over 30 minutes on day 1 of a 21-day cycle. So disease response assessment occurred every 2 cycles, that is 6 weekly, and the clinical lung cancer treatment was continued till disease progression or untoward toxicity. Accrual goal was 40 response evaluable patients, that is what was needed. The primary objective of the study was to evaluate the response rate, overall response rate as per the RECIST 1.1 criteria. A key secondary objective was the assessment of investigator assessed progression-free survival. And the telisotuzumab dose was administered at 2.7 milligram per kg over 30 minutes. Disease response occurred at every 2 cycles, that is 6 weekly. So now comes the results. 49 patients, 14% of the screen patients were assigned to this, and 28 patients were enrolled in cohort 1 and cohort 2 in totality, and 23 were eligible. Overall response rate was 35.1% in the non-squamous EGFR wild type cohort, whereas with 53.8% in the c-MET high group and 25 in the c-MET intermediate group population. But was modest in the squamous and EGFR mutated cohorts. So the median overall survival and the progression-free survival was 5.6 months and 2.4 months respectively. 10 patients had a stable disease as their best response, and the disease control rate was 52%. So this is the patient demographics demographic chart, which was well matched. The median age was around 65. The number of patients evaluated was 23, of which around 57% were male. Race-wise, what we saw that the white population was more. It was 91%. Asians were very less. What was only 9% of the total population which was done, and of these, number of lines prior therapy of stage 4 squamous cell carcinoma received in most of the patients, and performance status was 0 or 1 in most of the patients which we saw. And this is the study biomarker and gene alteration detected on the NGS screening, of which the median was 180 and the range was 150 to 260. So the different genes which were seen and the copy number alterations which were also seen has been placed in the table. So the adverse effects which we saw was seen in the trial, which was more common was fatigue, which was seen in around 9% of the patients, grade 2 or grade 3 fatigue. And in some patients, we had some liver dysfunction in the form of high bilirubin or raised or transaminitis. This was also seen in some 4% of the patients. So, and hypophosphatemia was also seen in some of the patients, which was significant. So in discussion, although MET protein overexpression is common in non-small cell lung cancer, strategies thus far to select patients based off for this treatment for with anti-MET monoclonal antibody and small molecule inhibitor of MET have failed to show a clinical benefit in large randomized studies. Telisotuzumab vedotin did show some clinical activity with a disease control rate of 52%, which is a meaningful benefit in patients with refractory squamous cell carcinoma, where there is an unmet need for improved therapeutic options. Pneumonitis was an unanticipated toxicity observed in our study and was not an expected off-target effect. So thank you. So
thank you, Dr. Tanmay. Thank you.
Okay.
Next is the